When you think about rosacea, you probably picture that classic bright flush, right? The redness, the inflammation.
Mhm.
But there's this other side to it, a much more severe, advanced presentation, usually right on the nose, that progresses to this really significant skin thickening.
And that's Phymatous rosacea, or PPR.
Exactly.
It's really the end stage of a long inflammatory journey. It's what dermatologists will classify as rosacea type 3. And the term most people might have heard or seen is rhinophyma.
Rhinophyma. That's the permanent enlargement of the nose.
Yeah, it's a very clear physical sign that the inflammation has been, running unchecked for a very long time.
So for our deep dive today, we're going to pull from the sources you brought and just really break down what is happening beneath the skin. We want to uncover the causes, genetics, immune issues, even a specific bacteria.
Right.
And then we need to get into the full spectrum of treatment, because stopping the inflammation is one thing.
But removing the tissue that's already there, that's a whole different ballgame. I think what's so essential for you to grasp right from the start is that this is a chronic inflammatory process that goes way beyond just surface redness.
It's structural.
It is completely structural. It results in irreversible changes.
Right.
We're talking about tissue, scarring, fibrosis, and that significant skin thickening. So understanding the pathophysiology, the actual chain reaction happening in the skin is just critical.
I think that's the perfect place to start. We really have to identify what this looks like, because the severity is what sets it so far apart from typical rosacea.
Absolutely.
Okay, so PPR is rosacea type 3. But what are the physical symptoms that tell you someone's crossed that line into the Phymatous stage?
The visual cues are, well, they're really distinct and textural. You're not just seeing red, smooth skin anymore.
Right.
You're seeing thickened, bumpy skin. You're seeing enlarged pores and this deep, irregular surface nodularity.
The sources used a fantastic descriptor for that texture.
Yeah, they did. They said it often resembles an orange peel.
That just clicks. It makes it so tactile in your mind. It's not just redness. It's a change in the skin's whole architecture.
It really is.
And while rhinophyma, the nose, is the most recognized sign, where else can these changes happen?
Well, basically, anywhere sebaceous glands are concentrated. The nose is definitely primary, but you can see this thickening on the chin that's called gnatophyma.
Oh, interesting.
Yeah, and the forehead, the ears, and sometimes even the eyelids can be affected.
So if we were to look, under a microscope, what is actually causing the skin to bulk up like that?
It's a vicious cycle, and it's all driven by that chronic inflammation. The inflammation triggers hyperplasia.
Hyperplasia. So that's the enlargement of the glands themselves.
The massive enlargement of the sebaceous glands, your
Yeah.
oil-producing glands, yeah. And at the same time, it's triggering fibrosis.
Okay, and fibrosis is essentially scar tissue.
Think of it as internal scar tissue. Exactly. The body is just laying down all this excess connective tissue because of the constant irritation, and that permanently thickens and distorts the area. It's a complete structural alteration.
That seems like such a critical distinction, because most people think of type 1 rosacea, the flushing, or type 2, the acne-like bumps.
Right.
So if type 1 is flushing and type 2 is bumps, what's the tipping point that makes type 3 lead to this irreversible thickening?
The difference is really depth and persistence. Type 1 erythema telangiec ectatic rosacea is mostly vascular.
All on the surface.
It's all about surface redness, flushing, visible blood vessels. There is no tissue thickening. And then type 2 papulopustular rosacea, that involves inflammatory bumps and pustules, but the inflammation tends to stay in the upper layers of the dermis.
But with type 3, the inflammation is just so chronic and so deep that it's actually changing the tissue architecture itself.
That's it, exactly. It recruits immune cells that aren't just there to clear up a pimple. They're activating processes that lead to the permanent deposit of fibrous tissue and the overgrowth of those glands. The body is literally building new, unwanted tissue.
And before we move on from this section, let's touch on that demographic surprise. This condition overwhelmingly affects men over 50.
It does.
Why that strong gender skew?
Yeah, the data is very clear. Onset is usually after age 30, but it really hits men over 50 the hardest. We'll get into the why a bit more soon. But it's directly connected to hormones and, the size of those sebaceous glands. It's much, much rarer in women.
Okay, so now we get to the core mystery. The sources all say the exact cause is unknown, but it's multifactorial. Inflammation seems simple, but here it becomes a structural problem.
Yeah.
What are the biological miswirings that create this state?
It really starts with an inherent vulnerability. There's a genetic predisposition. If you have a family history, your risk is definitely higher. But the mechanism is really this immune system dysfunction. The body mounts an abnormal, over-the-top response to environmental stimuli, and that leads to chronic, persistent inflammation that just accelerates those deep changes we talked about.
So the immune system is just constantly overreacting.
Constantly. It's turning molehills into mountains, and in this case, the mountains are permanent.
Let's talk about those enlarged oil glands. Making too much oil is one thing, but how does the sebaceous gland itself become a driver of the physical enlargement?
So the overactive glands produce a lot of sebum, which can be irritating. But more importantly, the inflammation itself feeds back into the gland,
Right.
and it causes the gland to grow in size. That hyperplasia is a defining feature of PPR. The gland isn't just producing more oil, the entire factory is enlarging and crowding out healthy tissue.
This is where it gets really interesting for me, the microbiological link. The source material specifically points to a bacterial component.
Yes. The role of Bacillus oleronius is a fascinating piece of the puzzle. This isn't really an infection in the way we usually think of it, but the presence of this bacterium is thought to trigger a very specific, exaggerated immune response in people who are already susceptible. It's one of the key inflammatory triggers that fuels the whole process.
So you've got genetics, an overactive immune system, enlarged oil glands, a specific bacterial trigger, all layered on top of the underlying vascular abnormalities that started the whole thing.
It's a comprehensive cascade.
Perfect storm.
It is. And this cascade is then made dramatically worse by external factors. These are the triggers that cause flare-ups, and they do it by increasing blood flow, dilating blood vessels, and just flooding the area with more inflammatory markers.
So give us the list. What are the major triggers that patients really need to avoid?
Environmentally, you have the big four: sun exposure, hot weather, cold weather, and wind.
Anything that stresses the skin.
Anything that stresses the barrier or causes vasodilation, yeah. Then on the lifestyle side, think heat and spice. Spicy foods, because of the capsaicin, and hot beverages like coffee or tea.
And of course, the ever-present stress factor.
Precisely. Emotional and physical stress are huge systemic triggers. They activate these neuroimmune pathways that just make inflammation worse. Poor sleep, hormonal shifts like menopause, even certain medications.
Which medication?
Things for high blood pressure, for example. Anything designed to dilate blood vessels can unfortunately make PPR worse.
And we can't forget what people are actually putting on their skin.
Right. Harsh cosmetics with alcohol, fragrances, or astringents. They actively inflame an already compromised skin barrier. For someone with early rosacea, using the wrong products can absolutely accelerate that progression towards the Phymatous stage.
Let's circle back to that demographic split for a second. The fact that it's so prevalent in men. Do all these triggers and factors just interact differently with male physiology?
They absolutely do. For one, men naturally have larger sebaceous glands,
So more oil.
more oil, and more raw material for inflammation to act on. Higher testosterone levels are also thought to influence the size and activity of these glands, driving that hyperplasia.
Okay, that makes sense.
Then you combine those biological facts with a behavioral one. Men often delay seeking treatment for years. They might let type 1 or type 2 progress untreated, and that creates the perfect storm for developing type 3.
We've established that this condition is irreversible without some kind of intervention. So the treatment strategies, they have to be hierarchical, right? Depending on how severe it is.
Exactly.
How do you distinguish between treating, say, mild PPR, just the early signs of thickening, versus that severe bulbous nose where there might even be functional issues, like trouble breathing?
The treatment goal fundamentally shifts. It goes from being purely anti-inflammatory to, well, to tissue destruction and removal.
Right.
For medical management, we start by trying to suppress that underlying chronic inflammation. We'll use systemic oral antibiotics like doxycycline or minocycline.
But not for an infection.
No, primarily for their potent anti-inflammatory effects, not their antimicrobial ones.
And for the really severe cases, the sources mentioned a pretty heavy hitter medication.
Yes, oral isotretinoin. It's reserved for severe progressive PPR because it has this unparalleled ability to shrink those enlarged sebaceous glands and dramatically cut down on sebum production.
So it's basically forcing the oil factory to shut down.
That's a great way to put it. It addresses the primary source of the hyperplasia.
So we stop the factory with isotretinoin, we calm the inflammation with antibiotics. What about topicals for maintenance or for milder cases?
Topicals are still important. Retinoids, like tretinoin, help normalize cell turnover and improve the skin's texture. Azelaic acid is a workhorse. It's anti-inflammatory and antibacterial.
Okay.
Metronidazole is another key anti-inflammatory. And while it doesn't affect the thickening, bromonidine gel can be really helpful. It constricts blood vessels to immediately reduce that debilitating redness.
But if the medications aren't enough, that means the tissue architecture has already fundamentally changed,
Right.
and you need an architectural solution. This is where we get into the interventional procedures.
Right. Once that fibrosis and gland enlargement are advanced, procedures are needed to physically remove that excess irreversible tissue. Traditional methods are things like surgical excision, dermabrasion, or electrosurgery.
But the gold standard today is more about precision,
It's
right?
all about precision energy devices.
And that means lasers. Why are lasers so effective here?
High-powered ablative lasers, like co-Euros and erbium-YA, are the tools of choice. They work by essentially vaporizing the layers of thickened tissue and the enlarged glands with incredible precision. The goal is to reshape the tissue, restore a more natural contour.
And it's not just cosmetic.
Absolutely not. If the nose is severely obstructed, laser ablation can significantly improve functional issues like impaired breathing.
It sounds incredibly targeted. But we can't just rely on these aggressive interventions. Let's step back and talk about that foundational preventative layer,
Hmm.
daily skincare.
Yes. This is completely non-negotiable for preventing progression and recurrence. It starts with avoiding your triggers and using a daily high SPF sunscreen, but we have to address the underlying vulnerability of the skin itself.
And the sources drew a really interesting parallel here between Phymatous rosacea and atopic dermatitis when it comes to the skin barrier.
That's right. The chronic inflammation completely compromises the skin's protective barrier, much like you see in eczema. This leads to increased transepidermal water loss, TEOUL, and it just leaves the skin vulnerable, irritated, and unable to protect itself.
So you have to actively restore that barrier.
It's like fixing a leaky roof. It's fundamental.
So what are the specific ingredients we should be looking for to rebuild that barrier and soothe this type of inflamed skin?
You need safe emollients that won't cause more irritation. The sources specifically highlighted fatty alcohols like cetyl and ceteryl alcohol.
Now, the word alcohol can scare people.
It can, but these are completely different. They're safe, waxy materials that act as emollients. They strengthen the barrier and lock in moisture, unlike, drying, irritating alcohols.
And beyond those base emollients, what else can help calm that constant redness?
You want soothing ingredients, things like manuka honey, aloe vera, hyaluronic acid in your moisturizers. They maintain hydration and can actively reduce that facial erythema.
Yeah.
But for a specific boost, the sources mention hypochlorous acid spray.
Tell us more about that. How does that mimic the body's own immune response?
It's fascinating. Hypochlorous acid is actually what your white blood cells produce naturally to fight off bacteria and inflammation. So when you apply it topically, it offers this soothing antimicrobial effect without being irritating at all. It helps break that cycle.
So to kind of synthesize this whole deep dive.
I'd say the bottom line is that Phymatous rosacea is this complex progressive disorder. Chronic inflammation leads to permanent fibrous tissue changes. And effective management absolutely requires a multi-pronged approach. You have to suppress the inflammation, you have to stop the gland overgrowth, you need specialized removal for severe cases, and you must fundamentally restore the skin's barrier.
And early intervention is key.
The earlier you start, the better the chance of preventing those severe, irreversible alterations.
Okay, that connection between inflammation, stress, and structural change is just so compelling. We know that emotional and physical stress are these powerful triggers, right? They activate neuroimmune pathways that accelerate tissue damage. So if chronic inflammation is the core mechanism driving all this skin thickening, how might further research say focusing on the gut-skin axis or neuroimmune modulation offer new, non-topical solutions? Could we prevent this progression entirely by calming the systemic stress response before it ever even manifests on the nose? That's something worth mulling over.